Hi class and welcome to week 6. So this week we're talking about the mood disorders and the various mood disorders that exist in the DSM and suicide. So suicide falls under mood disorders due to it being very common among people who suffer from major depressive disorder. So they're really serious. Obviously, mood disorders are it can lead to suicide, can lead to a sense of hopelessness, and some of those characteristics are in our diagnostic criteria. And so we want to really pay very close attention and learn about the mood disorders and how to recognize signs and symptoms when someone is really struggling. So they're less common in prepubescent children. However, the incidence of mood disorders rise dramatically in adolescents. They're seen in younger boys and girls, but more frequent in adolescent females. So when you see a mood disorder in children, it's of equal frequency. So girls and boys will suffer from a mood disorder at a prevalence rate that's very similar. However, it increases dramatically for teenage girls than it does for teenage boys. And those over the age of 65, estimates suggest that half or more suffer from symptoms of depression. So this is something we want to be mindful of. And when we think about signs and symptoms of a depressive disorder or other mood disorder, we want to know that we want to keep in mind that the prevalence rates are pretty high. Bipolar disorder is seen in about 1% of children, adolescents, and adults. And mood disorders can really vary across cultures in terms of its symptom presentation. And so we want to think about that subjective feeling of depression and what it looks like in different cultures and different people's experiences of that. So be reviewing that in your chapter and your PowerPoints as well. The causes of a mood disorder is very complex. It is an interaction of biological, psychological, and social factors. And so from that biological perspective, researchers are particularly interested in the stress hypothesis and the role of neurohormones. Psychological theories of depression focus on that learned helplessness theory and this idea that no matter what I do, it's never going to get better. And there's a whole theory around that, as well as the theory of the cognitive schemas, such as our negative outlook and negative cognitive style. And finally, the interpersonal disruptions and sociocultural factors, such as gender and social support, that can contribute to a depressive or another mood disorder. There's a variety of treatments that have been shown to be effective for both the biological and psychological components of a depressive or another mood disorder. And those who do not respond well to an antidepressant for a mood disorder, for symptoms of depression, they've used other kinds of dramatic physical treatments like electroconvulsive therapy, which is called ECT, which is not used as frequently, but for those who don't respond to kind of the traditional treatments, they may give that a try. The other thing that's a little more recent is the transcranial magnetic stimulation. It's less invasive than ECT, and it has been demonstrating some pretty positive results in terms of depressive symptoms. And so that's a little bit of a newer treatment, but they are starting to see some results with that. Cognitive behavioral therapy is one of the main therapies that we use, as well as interpersonal therapies for mood disorders. So when we think about bipolar disorder, though, one of the medications that we see very frequently is a lithium or another the anticonvulsant class of medications, as well as psychological interventions to manage those interpersonal and the practical problems that they're having in terms of their dynamics. Relapse and recurrence of mood disorders are very common, and therapies and the interventions can be long-term. Treatment efforts need to focus on kind of maintenance and preventing relapse or recurrence. Sometimes medication management is huge with this population, particularly with the bipolar disorders, as sometimes the side effects can be something that people don't like. Also, the experience of the manic episode is something that is I don't know, the word liked, they like that experience of that manic episode, and when the medication sort of subdue that experience, they feel dulled and feel like they that there's sort of this impact that's negative on their personality and who they are. Pay special attention to the factors related to suicide, as we do see risk for suicide in the mood disorders. Suicide is most often associated with these disorders, and it can occur in the absence or the presence, but we do see it with major depressive episode and bipolar disorder. It is the leading cause of death among all people in the United States, and among adolescents, suicide is on the rise. People or experts in this field are suggesting that the actual rate of suicide might be drastically underreported, leading to concerns that it's actually a bigger problem than we even may think. So we need to really pay attention and understand the factors that relate to suicidal ideation. This is serious thoughts about committing or thought about hurting oneself or killing oneself. The suicidal plan is that detailed kind of method with a means and access to the means, as well as kind of that planful method, like this is how I will do it. And also the attempts. Even if they haven't been successful, the history of a suicide attempt puts someone at more risk for a future attempt or a success at suicide. So really learning about those risk factors is key for people who suffer from one of these mood disorders and may have thoughts of suicide. The psychological profile of an individual who has in fact committed suicide is something that people are trying and experts are reconstructing, so that we can get more clues as to how these signs and symptoms may have been missed. So really, I hope you enjoy this week's chapter, and please, again, feel free to email me if you have questions.